My name is Michael Cooney. I'm one of the physicians here at EVRM, ophthalmologist, retina specialist. When I see a patient with diabetes and I have, 10, 15 minutes to kind of tell them everything they need to know, which we're going to take an hour to talk about, more or less, maybe less. The point is, I can't get everything across that you all need to know in 15 minutes. So that raises lots and lots of questions throughout the course of care that we never quite get to. So kind of sitting down and giving a formal lecture about it goes a long way towards helping people understand the disease. And if you understand the disease, you understand the demon that you're fighting against. If you don't understand the demon you're fighting against, the chances of you winning are just a lot less. We are Vitreous, Retina, Macular Consultants of New York. That's the office you're in here. There are 11 of us, okay? We are one of the oldest retina practices in the country. I don't mean by age, I mean by history, okay? And one of the original retina practices in the world for that matter. And there's a bunch of us. We all do ophthalmology, take care of diabetes, do lots of retina things like macular degeneration. And we have 3 offices. You're in our main office at 57th and Park. We have a Brooklyn office out near Kings Highway. And then we have a White Plains office up about a mile north of White Plains. Okay, so disclosures. I'm a consultant to Bausch & Lomb. I do some speaking for Genentech, Bausch & Lomb, and Regeneron. I have absolutely no financial interest in anything I'm about to speak to you about. So here's a common conversation that I run into when I sit down with a brand new diabetic patient that walks into my office. Not everyone, but this is a common conversation. Okay, here it goes. They say to me, I have a touch of diabetes. Does that sound familiar to anyone here?
Yeah.
All right.
Borderline.
So borderline, I don't know, I'm pre-diabetic. It's this big gray area, okay? When I ask them how their sugars are doing, this is what I get. 99% of the time. My sugar was normal this morning. Okay, well, I've learned a lot. Okay? I don't know what that means. I honestly don't. What's your hemoglobin A1C? That's my question to them. What's that? To the credit of New York City's Board of Public Health, whatever that is, that probably wanted to do the soda ban and all that stuff, which I thought was a great idea, by the way. Every now and then, a couple years ago, on phone booths in New York, when they still existed, maybe on the sides of bus stops now, there was a public health campaign that actually said, and it had something about know your A1C. Did anyone see that? Do you remember seeing that? I was so impressed when I saw that because that was the first time I ever heard anyone publicly speaking about that in a public forum. So, but a lot of people have no idea what that is. No idea. And I'm going to tell you why knowing that number is important and how it plays into a lot of things that affect your eyes. Yep. They say they exercise. I say, you exercise? And they say yes. And I look at them and they're inevitably 30 pounds overweight. They say they have a little bit of foot numbness. They say they see fine. When was the last time you had your eyes examined, I ask? I had my glasses checked 2 years ago. Now, what's different there than what I asked?
The glasses.
Yeah, glasses. I mean, glasses check is not necessarily an eye exam check, but this is the common conversation. Okay. Who's taking care of your diabetes? I don't know his or her name. He or she tells me everything's okay. I don't know why I have to see you, they say to me. And I just need reading glasses. This is the common conversation, guys. I dilate their eye, I look inside. Now, you're going to see soon what a normal retina looks like. I'll tell you that this is a retina that's got massive scarring and massive problems from diabetes, like to the nth degree. Their vision is not surprisingly from here, regardless of this train wreck that is going on, 20/20. And they have no idea that they're on the verge of going blind. And this is a common thing. So the take-home message, if you all decide to zone out from here, sleep, check your phones, whatever you want to do, here's the take-home message, and listen to this. Any blood sugar problem, I don't care if it's your pre-diabetic, diabetic, type 1, type 2, whatever it is, you need to have a dilated eye examination immediately if you have not had one, with an ophthalmologist or retina specialist, not just an optometrist for a glasses check or things like that. We're talking about dilated eye exam, right? The type that you're blurred for 5 hours afterwards, that kind of eye exam, okay? You do not just need an eyeglass check, Okay, it's beyond that. It has nothing to do with glasses. You can have massive eye disease and have absolutely no symptoms at all. Don't rely on our pill society. It is easy to take a pill for everything today. You can take a pill if you're sad, you can take a pill if you're happy, you can take a pill for anything. And we rely on a lot of that, right? It's much harder to change your behavior because it's hard to change behavior, me included, okay? And I don't think I have anything on the last bullet here, but diabetes is one of those things that can definitely, and I'm not saying this to scare you, diabetes is one of those things that can cause complete blindness. It just is. Macular degeneration, everyone heard about that? That's another big problem in our society. Lots of problems. Macular degeneration might cause you to lose your straight ahead vision, but macular degeneration does not cause you to go pitch black blind. Diabetes can cause you to go pitch black blind, okay? Take good care of yourself, and again, this is hard to do. It's hard enough for me to do it. Okay, and I'm a physician. Exercise, weight loss, eat well, don't smoke. Some of that stuff sounds really easy. Some of this stuff is the hardest stuff in the world to do. So moving into more diabetes. Diabetes, as you all know, who have diabetes, can affect your whole body. Okay, we're going to be talking mostly about the eye tonight, but I want to give credit to the entire body. It affects the eye. We call that diabetic retinopathy. It affects the kidneys. It's called diabetic nephropathy. It can affect the nerves, what we call diabetic neuropathy. It increases the risk of stroke, coronary heart disease, whole body disease, and there's lots of different problems that need to be looked at. So here's the thing about diabetic retinopathy, and we start now focusing more towards the eye for the rest of this lecture. The busy slide, ignore it, except for the green. At their first study visit, 83% of patients with diabetic retinopathy, which means stuff going on in the eye, about 80% of them with vision-threatening retinopathy, meaning that they could lose vision at any moment, 83% of them had no idea they had any vision problem whatsoever. That's huge. That goes to my first slide of there was a problem there, but you didn't know you had it. If you have diabetes type 1 and diagnosed usually at a younger age, you should have an eye exam within 3 to 5 years of diagnosis, and thereafter every year. If you're diagnosed with type 2, hear this clearly, okay? 99.99% chance you've had diabetes type 2 for longer than the time that you just found out about it, okay? Which means it's been going on for longer. You need to get in immediately for full dilated eye exam within a week or two or a month at the most of finding out you have that, because the chances of you already having eye findings is high because it's been going on for longer than you just finding out about it. And then if you have nothing, if they find your eye doctor says everything looks good, at a minimum, once a year, you need to have your eyes dilated. It may be more frequent if you are found to have certain findings that need to be managed and monitored more carefully, okay? So if we look at the risk factors for what we call diabetic macular edema, and I apologize for not spelling this out, we're going to talk about this later on, but diabetic macular edema, which we'll get into in a minute, is one of the most common reasons why people don't see well, which is where the retina, which is the back part of the eye that's like the film of a camera, we're going to go through all this in a second, gets swollen, okay? So it's one of the most common reasons why people with diabetes don't see well, okay? What's the risk factors for that? How long you've had diabetes? The longer you've had diabetes, the more out of control your blood sugars are, the more likely you are to run into any of these problems we're talking about. Kidney problems included, numbness in your feet included. So if you've had diabetes for greater than 10 years, you're 11 times more likely to have that problem. Secondly, the A1C. This gets into why you should know your A1C for many reasons, but this is one of them. For every 1 point increase above normal, and normal is around 5.5, okay? Just for argument's sake. So people come in and say, I have an A1C of 8. What does that mean? Well, normal's 5.5. Okay? Well, let's just say it's 5 just for purposes of argument's sake. So you're around an 8. That's 3 points above normal. For every 1 point above normal, the chances of you having this problem go up 50%. So if you are running an 8, your chances of having diabetic macular edema is, guess what? If I'm doing my math right, 3 times 50 is 150%. I see patients walking into hemoglobin A1Cs of 14 or 15. So what's that? That's 10. Am I doing that right? 10. 10 times, that's a 5,000, whatever it is. You get the point. I can't do my math. It's a large number for every 1 point. So you've got to control your A1C. You need to know what your A1C is. All right? So that number needs to be controlled. Obviously, controlling high blood pressure, high cholesterol, all the things that you would think of normally to control, to protect for heart disease are the same things you need to be controlling and protecting for macular retinopathy. All right, now we're going to get into the nuts and bolts of it. I'm going to assume that most of you don't know eye anatomy, and you'll thank me for that, okay? Because otherwise you would be lost for the rest of the lecture, which is not an uncommon thing for lecturers to do. So here it is. Here's a camera. Now I'm talking old-fashioned cameras. I'm not talking about the iPhone camera because I have no idea how that works. I don't. But I'm talking about an old-fashioned film camera. And everyone in this room, I'm not calling anyone in this room old, but I like photography and I grew up with film cameras, so I know pretty much looking around here, there's no one here that's at least younger than I am. So you all know what film cameras look like, right? Okay. So here's an old SLR camera, and the way a camera works is the lens does what? Two choices. Okay, good. Focuses. The lens of the camera focuses light onto the what? The film. If the lens is out of focus, the picture on the film is out of focus, okay? If you have the most expensive, beautiful, focused lens in the world on your camera, but you have rotten film, how well is that picture going to come out? Right. All right. There it is. That's diabetes. Okay? We're going to get into that. Here's your eye. You have the front part of your eye, which I'm not going to spend a whole lot getting into, but you have your what's called the cornea, and then you have the lens. The lens is the thing that becomes a cataract over time. And guess what these two things are responsible for doing? They're sort of like the lens of the camera. They are responsible for focusing light onto the back wall of the eye, which is where a thing called the retina is located, which is the same thing as the film. And here's the light coming in, it's focused, okay? And the retina is a it's part of your brain, okay? It's nerve tissue, it's very sensitive, and it's responsible for producing vision. So if the retina is not working right, then your vision is not going to be working right. Despite if everything else in your eye is perfectly normal, if the retina is not working right, the picture's not going to come out right. This is a blown up picture of what the retina actually looks like from a sideways perspective, okay? And what this is the retina is made up of millions and millions of vision cells that are basically a fancy electrical grid where one cell connects to another cell, and they all communicate with each other and process electricity. That's what all the retina is. It can process, it's an electrical grid. So if you go in with a hammer and beat the heck out of an electrical grid or throw water on it or all kinds of stuff, how well is that electrical grid going to work? It's not going to work very well. It's going to have problems. And they take light and they turn that light into electricity. Okay? So light is not electricity, right? Light is light. But the rods and cones take light, turn it into electricity, and then once it's turned into electricity, it starts going through this grid, this electrical grid, out some nerve fibers, out the back of your eye through what's called the optic nerve, into your brain. This is all carrying this electrical signal. And in the brain, the back of your brain, right back here, called the occipital cortex, that electrical signal in your brain is turned into vision. You do not see with your eye. You see with your brain. The eye is just a camera that focuses light from the world onto the film, which is the retina. The retina turns it into electricity, and the electricity goes out through nerve fibers to your brain, where it then turns into vision. So if I go in here and I cut the nerve, what happens to the vision? It's gone. It's like if I have a light plugged into a wall and I cut the cord, well, the light looks great. I cut the cord, which is the nerve, light's out. So here we are, the retina, old-fashioned film. So when we dilate your eye with drops and make you blurry and look in there with all the little lenses and those obnoxiously bright lights that undoubtedly you all cringe saying, oh, light hurts. Well, that's a good thing because that means things are working, okay? Better that than I don't see the light. This is what we see back there. This is exactly what I see when I look at your eye. This orange thing is the what? The lens, the cornea, or the retina? The retina. And it's orange. It looks like a planet. It's actually a really cool looking thing. But I love what I do. It's really kind of cool to look at this stuff. To orient you, this thing here is the optic nerve. I talked about that. That's where the nerve fibers exit the back of the eye and then go back that way to the brain where vision occurs. These are the normal arteries and veins that bring blood and oxygen and circulation to your retina and nutrition in order to keep the retina nourished. Every tissue in your body has a circulation, right? From your earlobe to your little toe to your pinky finger. If it doesn't have a circulation, what happens to it? It doesn't work. It falls off. It's dead. Okay? Circulation is everywhere. This area here, this big area that I'm circling here, is called the macula. It is the part of your retina that you use for your straight ahead vision. Not your side vision. This is gross vision. But when you read, that image is landing right here on your macula, part of your film. And guess what? The very center of that, the bullseye of that, think of this like a dartboard, is called the fovea. And that is where your finest straight ahead vision happens. So when you read a book, see a face, watch TV, all that is happening right in this little area here, which is something that is fractions and fractions and fractions of a millimeter in size. Okay? We can think about this, and I will oftentimes tell patients that the macula is like a dartboard, with the bullseye being the most sensitive area. So anything that affects this area can affect your straight ahead vision. Now what I'm not showing you in this picture is actually the retina is bigger than this. It goes out further into the sides, and that retina is responsible for your side vision. If I hold a book out here, can I read a book with my side vision? No, I can tell there's something there. It's gross vision, but I can't read that book until I bring it in, and that image is landing right on my macula. So the macula is a really important sensitive part, and unfortunately, guess what diabetes does? It causes a lot of damage to the macula, as does another disease, macular degeneration, which we're not going to get into tonight. Okay? So this is normal. Remember what this picture looks like. If we cut the retina, turn it on its side, look at it sideways, we get a picture that kind of looks like this. This is a real retina that's just been photo manipulated to show you what I'm showing you here is there's multiple layers of cells here. Millions of cells that are all vision cells that are all, you can see how organized this is. This organized or disorganized? It's very organized. And it's organized because that's the electrical grid that's all perfectly talking to each other where all the cells are connected. In certain cases of diabetes, you'd be sort of like me taking a hose, sticking it in here and turning the hose on and letting the hose run and all the layers get separated and distorted and things like that. Okay? How well do you think that retina is going to work if that's the case? Not very well. We kind of showed you this before. I'm going to skip that. So one of the ways that we can actually see, there's very few places in your body where you can actually see the circulation. I guess one could have a catheterization and look at your coronary arteries, but you're still not going to see the level of detail that I'm going to show you in a second. There's only one place in your body you can look into and see the finest capillaries that exist in human existence. And guess where that is? The retina. Okay. And one of the ways we do that is what's called a fluorescein angiogram, where we inject a fluorescein dye into the vein, and that dye then gets into all the blood vessels in your eye, and we can actually highlight them and see them. And we've got an outstanding photography crew here who does this on a daily basis. Thank you all. So here is what the retina looks like on an angiogram. Okay, now it's a black and white photo. Okay, it is actually orange, but this is a black and white photo. And what we can see here is that the dye has filled all the arteries and filled all of the veins. And you can see that these arteries, which are the thinner ones, what do they do here? They branch, they branch, they branch, they branch, and you can follow them, but at some point you ultimately can't see them any longer, right? You see the branching pattern? What does it remind you of? Remind you of this? There's no difference between the retina circulation and how it branches off, and guess what? That's the case in every tissue in your body. Every tissue looks like this. You just can't see it. And a branching tree. So if I have a branching tree, what part of that tree, if a hurricane comes through or a big windstorm, is going to get damaged first? The outermost. And I'm going to give you three other choices. The tree trunk, the big sturdy branches, the thin branches, or the stems of the leaves. Which one gets hurt first?
Stems of the leaves.
Why?
The thinnest.
They're the thinnest. They're the smallest. They're the most vulnerable. Okay? Same thing happens in diabetes. This is a magnified, specialized photograph of what the finest capillaries in your body actually look like. This is the retinal circulation. This is, guess what? The bullseye of the center of your vision is right there. The bullseye of the dartboard. You can see how small and thin these capillaries are. And you can see they start out big, they branch, they branch, they branch, and they come down to this. These are the stems of the leaves. And when diabetes is going to affect something, guess what it's not going to start with? It's not going to start by affecting this big, thick one. It's going to affect these small, tiny little ones, and it doesn't take much to cause them to have problems. And if I close down capillaries in your retina, there become, by definition, areas of your retina that are not getting nourishment, circulation. And what's part of circulation that's really important to breathe and to live with? That's begins with an O. It's called oxygen. Okay. If there's certain areas of your retina that are not getting oxygen because these little capillaries shut down and there's this area there's just no circulation, your body responds to that and says, I'm going to heal that problem. I don't have enough circulation here. I have an idea. I'm going to grow a new blood vessel to solve that problem. It's a great idea. But it causes in the eye a lot more problems than it helps. And we'll get into that in a minute. So you saw a normal angiogram here a second ago. This is what a normal macula retina looks like. There's no big haze of whiteness here. All the dye is confined inside the blood vessels. And here is a retina from diabetes on an angiogram. Looks a little different, doesn't it? I'll orient you. Here's your nerve. Here's the macula. Here's the center of your vision. But what do you see here? I mean, there's all kinds of what's going on. Like, there's this white stuff here. That's a blood vessel growing abnormally. You got all these little white dots here. Do these capillaries look healthy? They're kind of leaking. It's like a hose that's leaking because the dye is leaking out of them because they're damaged. Now, we can look at the retina from a sideways perspective because we have, again, photography equipment that allows us to do that. These are images we get in the office every day where the retina is cut sideways, and we look at it from a sideways perspective, and this is the retina. It looks pretty similar to that organized, layered thing I showed you a minute ago that had all the bright colors on it. Well, this is a black and white picture. But again, you can appreciate all the fine organization and layers. The center part of your vision, where your finest vision happens, is this little dip right there. That's the bullseye on the dartboard just looked at from a sideways perspective. Guess what diabetes oftentimes does? It causes this area right here to become swollen, and you lose the dip. And if you lose the dip, things aren't going to work well. Matter of fact, here's a picture of someone with diabetes. Same picture. Does it look normal to you? This looks pretty good. What's going on over here? It's swollen. This is a bunch of water that's in the retina that has then separated all the vision cells. They're no longer touching each other and talking to each other, and therefore vision doesn't work very well. This is a perfect example of what's called diabetic macular edema or diabetic swelling, which again is the most common reason why people with diabetes don't see well. All right, we're going to talk about diabetic retinopathy. We've been setting the stage for it, okay? So when you go to your eye doctor, ophthalmologist, they will look into your eye and look for certain things, okay? And they will kind of divide and grade your diabetes into two different things. We call it, you don't need to remember this, non-proliferative diabetic retinopathy, which means that you might have damage going on in your retina, like we see kind of this stuff here. You got little red spots, little aneurysms, little hemorrhages, a little bit of cholesterol accumulation in areas that you're not supposed to have it. And then in a more advanced stage where you have so much damage to your circulation that your body has decided to take upon itself to fix that circulation problem, where it starts to grow abnormal blood vessels that aren't supposed to be there. And these are like weeds that grow in a garden. They have great intentions, but they cause all kinds of damage. And that's what's called proliferative diabetic retinopathy. When you start getting into proliferative diabetic retinopathy, what can happen is these blood vessels can break open and bleed, and you get blood in your eye. The macula is somewhere underneath there, but how well do you think that person is seeing? You got blood right over the center of the vision, so they're not seeing well. And it's proliferative diabetic retinopathy that left untreated. This will ultimately cause complete scarring of your retina, complete retinal detachment, and people to go and lose their vision completely. With treatment, we have a very high chance of controlling the problem and significantly decreasing the chance of you losing vision. If you walk in with a major vision problem from diabetes, since this is nerve tissue that we're talking about here, nerve tissue is very, very sensitive tissue. If you've got a certain amount of damage that's been done that has affected the vision, the primary goal of anything that we're doing is to decrease the chance of you losing more vision than what you walked in with. That's just what the primary goal is. The secondary goal, which is what everybody wants, including your doctor, to be the primary goal, but it's nonetheless the secondary goal, is hopefully the vision can get somewhat better. But that's always a secondary goal because we're dealing with sensitive stuff here. So your doctor will look in and say, well, do you have a little bit of stuff going on in the retina where we see these little blood spots here? Again, that's a little bit, so we call that mild. We look in, maybe they've got a couple more little spots, we call that medium amount. Or do you have, just a lot of stuff going on? Or you see all this yellow stuff, white stuff, that stuff is not supposed to be there. That's all damage from diabetes. And we grade you, where are you on that spectrum? And based on where you are on that, decide, A, does anything need to be done today to treat you? So oftentimes there's not, we just need to watch. And B, when should I see you back? Because the more you have, the more chance you have in the near future of developing a vision-threatening problem. So I'm going to follow you more closely. So on a general statement, someone walks in with mild, say someone comes in and has diabetes and I look and they've got a completely normal eye exam. I say, see you in a year. and you got to come back in a year. If I look in, you got a medium amount, I'll say see you in about, maybe 6 to 8 months. You walk in and you got this kind of situation, even if we're not treating you, say see you in 2 months. Because the chances of you developing a problem is quite high at that point. We need to catch it before it starts running away. So grading and knowing where you are is really important for lots of reasons. So let's get into the good news. The good news is we can treat a lot of this stuff. We can't treat everything, okay? But we can treat a lot of this stuff. So here's the things you mentioned. You need to get every study in the book from time immemorial, whether you're type 1 or type 2, I don't care what you are. You need to get your blood sugars down. You need to get your A1C as low as possible. For purposes of this, I have it here less than 6, and normal is around 5.5. Okay, but your endocrinologist needs to set a target for you as to what's reasonable for you and your health. You've got to get your blood pressure under control. Blood pressure, think about it. It's the pressure inside these little blood vessels. How much pressure do you think this poor little blood vessel can take? I mean, not a whole lot, okay? It doesn't take much to blow it out, okay? Lipid control, your cholesterol, all that stuff, really important. So if I was to write a single prescription for everybody who comes in with diabetes, this is what I would write, okay? Exercise. And some of you are here, I've written this prescription for you. And you hate it when I hand it to you because you can't fill it anywhere. It takes work. Weight loss. And I would stop right there. This is kind of how we operate in healthcare. Lifestyle modification is the foundation. Then we got pills, and then we got surgery. Unfortunately, I spend a lot of time up here. Okay, doing advanced high-tech medicine. We all want high-tech medicine, but guess what? We could avoid it'd be better to avoid it all. One thing I will tell the patients all the time is the best thing you can do is stay away from doctors. Okay? Now, I don't want to tell you the diabetics that. Okay? By all means, you should see your doctors. But the point is, you don't want to have to need all this stuff that I'm going to tell you about in 2 seconds. You don't want to need it. If you need it, we got it. But you got to take care of yourself and do your work too. Because if you're not doing this, you're not doing that, you're eating at Wendy's and all the bad stuff we talked about, and you're not giving a crap about any of that stuff, here's what is going on, okay? Here's me, or any of my partners, and here's you, and it ain't a good picture, okay? Another analogy I'll use, if you're doing, your sugar's out of control and you're expecting me to do lasers and injections and all that stuff, and you're not doing your part, you're stepping on the gas pedal, I'm stepping on the brake, how well is that car running? That's what it is, okay? So you got to do your part. This is huge, guys. This is the most important slide I can show you. So what are some of the biological causes of this? This is just kind of gets into some of the stuff of why this stuff happens. So this is an example of somebody you can appreciate here. You can follow these capillaries down, and then they just kind of shut off. It's almost as if someone took a pruning shears and cut them off. And this whole area of the retina here does not have any circulation. You can kind of see there's nothing there. So that's an area of your retina that says, hey, look, I'm not getting enough oxygen. Let me release some little chemicals that will help me solve that problem. So when you have a heart, in your body over the course of the millions of years of evolution has adopted a couple ways about how it heals. Okay? Whether you get a cut in your hand, whether you have a heart attack, or you have a retina problem, it's all the same problem. You get a cut in your hand, you cut a blood vessel, you get a lack of oxygen to an area, blood vessels start growing in order to heal that and create a scar, and all that is driven by little molecules that are released that say, I'm injured. When you have a heart attack, you have an area of your heart that does not get enough oxygen, right? That's the definition of a heart attack. Then it doesn't work. The way a heart attack heals, if it heals, luckily if you survive it, is guess what happens? Little molecules are upregulated in the heart that tell new blood vessels to grow and reperfuse that area of the heart that's been damaged. That process is a good thing when you get a cut in your hand. That process is a good thing when you get a problem with your heart. The process is the same process that happens when you get a lack of circulation in your retina. The problem is the healing process causes more problems in the retina and doesn't help the situation. It causes more vision loss. Okay? So one of the molecules that's released is a molecule that we've identified in science called VEGF, which stands for, you don't need to know this, vascular endothelial growth factor, which I want you to think about like fertilizer. Okay? That you're going to have a bunch of weeds and you're going to take fertilizer and you're going to throw it on there. If you fertilize weeds, what happens to those weeds? They love it, right? Yeah, they grow and they grow and they do all kinds of things you don't want them to do because you're feeding it. You're feeding the beast. So this is what this stuff is. Guess what? We have drugs that deal with. We have drugs that block this fertilizer. Okay? We're going to talk about that. So these little fertilizer molecules, this is an example of a blood vessel. They float around, they land on what's called cell receptors and tell cells to go do abnormal things. In the case of diabetes, it ultimately tells a cell to grow and become an abnormal blood vessel, which can cause all that bleeding we showed you before and loss of vision. And they also cause lots and lots and lots of leakiness of blood vessels, sort of like taking a hose and beating it up, and now the hose has lots of leaky points. Okay? And now you got puddles all over the place. Here's the good news. We have drugs that are approved by the FDA that basically block those molecules. These have been around and approved by the FDA for diabetes for just about the last 2 or 3 years. Up until then, we'd never had these for diabetes. We've had these same drugs for macular degeneration since 2007. Before that, we didn't have any of this stuff, and we were stuck with things like lasers and things like that, which were okay, but these are far better. Okay, and this is just the advancement of science. There are medicines that all work, and we have 3 medicines that are out there that we can pick and choose from to help certain patients with diabetes if you have certain things. What are those things? Well, how do they work? I want you to think about these little iron filings, sort of like those little molecules, like those little fertilizers. Okay, so if I take these iron filings and they're free, I can throw them and sprinkle them and they can do badness. As soon as they land on the carpet, they can do badness. But if I take a magnet and I suck up all these iron filings before they hit the floor and they're all stuck to the magnet, do they ever get to the floor and cause the problem? No, they're stuck to the magnet. They're stuck there. These drugs work the same way. They are basically big magnets, simplistically stated, that go in, these are the magnets, and bind up those little fertilizer molecules and prevent them from ever getting to the cell. If they never get to the cell, that whole process of badness never quite happens. And that's how these drugs essentially work. So we can inject a bunch of magnets, and they last in the eye about a month, and then they wear away and there's no more magnets, but your body continues to be injured and it keeps wanting to produce more fertilizer. So guess what you need to have done again? You need more magnet put in your eye. Lasts for about a month, okay, wears off, your body's still injured because the diabetes isn't cured, the injury's still there, produces more fertilizer, what do you got to do again? Okay, you see where I'm going with this. These are ongoing things that form good relationships between you and your ophthalmologist because they're regular things. Okay, we'll get into this in a second. So here's another way that these drugs work. It's sort of like weed killer. So when you get an abnormal blood vessel, when you have really advanced diabetes and you get to the point where the blood vessels starting to grow abnormally that are going to cause all kinds of problems, well, here it is. Here's your weed. What happens if I spray that weed with weed killer? Looks like that. Is the weed gone? No. It's inactive. I've suppressed it. But if I leave that weed alone just like that, I haven't pulled it out,
it will grow back.
What might it start doing? It might start turning green at the ends. I got to spray it again. The point is, these things are ongoing things, and we want to keep things looking as suppressed as possible, which we do through treatments with injections and laser, which we'll get into in a minute, to keep this looking like this. Because if we don't get it looking like this, what's that weed going to do? It's going to grow and grow and grow and take over the garden. That's just what it's going to do. So someone asked, we can inject this in the eye. I know this sounds horrible, okay, but it's actually very simple. It doesn't hurt me at all to do it to you, okay? So, all right, but believe it or not, your eye does not have many nerve endings, okay? So I know this sounds really crazy, but we can put a little needle in the eye, and it's a really tiny needle, and we numb the air of the eye, and it's usually one of those things that people say, oh, that wasn't as bad as I thought it was. But to think about it before you've had it done once is one of those things that, trust me, it's hard to get your mind around, and I fully appreciate that, okay? But we can put a little needle in the eye, and we inject the drug right into the gel part of the eye, and then it floats around, and it binds up all those little molecules that are there to cause things to go bad. And that's what it is, and we can do this safely, and I'll show you how we can do that safely. So you might say, why on earth is he showing me pictures of carpets? Okay, I'm not in the carpet business. But what's the difference between this and this carpet? I've written the answers over there.
Total coverage and partial coverage.
Okay, so if I'm on the floor below and I've got a big sword and I'm standing below this and I stick the sword through the ceiling, is there any place on this area where I can stick that sword where I'm not going to hit the carpet? No, it's wall-to-wall carpet. I'm going to nail the carpet every time. How about if I'm in the floor below this and I want to stick a sword up through this floor? Is there an area where I can stick the sword where I'm not going to hit the carpet?
Yes.
Right, it's this area right here, okay? So if we look at your retina in the section of your eye, your retina is the orange thing. It lines the back wall of the eye, but guess what? Does it go all the way to the front? No, there's an area here that doesn't have any retina there, because we certainly don't want to stick a needle and hit your retina. We just don't want to do that, because that'll cause a retinal detachment. It's an area called the pars plana that has no retina. There's no blood vessels there conveniently, and we can stick needles in there all day long and not cause any problems. And that's the area we inject into. Okay. It's also the area when we need to do surgery on the eye for bad diabetic situations. We need to put instruments into the eye. We go in through these areas, and you'll see pictures of that in a minute. Okay, laser has been around for 60, 70 years, treatment for diabetes. Okay, we still use a lot of it. We use laser all the time because diabetes has been the standard of care treatment. It continues to be for lots of levels of diabetes in the eye, in conjunction sometimes with the medicines that we give as injections. Sometimes we'll do only laser, sometimes we'll do injections and laser. It depends on what's going on as to what we do. But laser basically it's a fancy way of creating little burns in the retina that are ways to help heal things, okay? And we use laser all the time, and it's little contact lenses put on the eye. The laser is focused onto the retina, and these are what laser spots look like in the retina. And to make a long story short, if you've got an area of your retina that's injured, but it doesn't have any circulation, it's an area of your retina that's almost dead, but it's not quite dead. Now, don't take that the wrong way, but it's an area of your eye that's just not healthy. And it's not healthy, it's not producing any vision for you, but it's an area that's continuing to release those molecules in the fertilizer because it's sick. And essentially what laser does, in a simplistic way, is it burns that area of the retina. You don't feel it really. Some people feel it. It burns that area of the retina, takes it from being kind of just sick retina and just kind of, in a certain sense, kills it off so that it doesn't really damage your vision at all, but it gets rid of that retina's ability to produce those molecules that were causing your problems. We use this all the time. That is a simplistic way of stating what laser does. So let's get into macular edema. Again, remember this retina, this is what it should look like, and it's massively swollen here. So we told you this before. This is the most common reason why people lose vision, where the center part of the vision gets all leaky. The hose has sprung tons of leaks. That fertilizer is only making that worse, and the retina gets massively swollen, and someone's vision doesn't work well. So again, here's the hose that's leaking. Here's the hose that's leaking. All that whiteness is the dye that's leaking out all over the place. Here's a normal looking retina, and this is what this person's retina looks like. This is the most common problem we deal with. So here's a patient, okay? Ed. I don't know who Ed was, but anyway. Those are his initials. Here's the center of the vision. You see all kinds of damage from diabetes here. There's all these little red spots. I would categorize this person as having severe non-proliferative diabetic retinopathy, and someone I'd be wanting to watch about every 2 to 3 months because they're at high risk of developing a problem. This person's angiogram has lots of leakiness, whiteness here, lots of damage that we need to be aware of and deal with. He's got poor circulation all over the place. This is actually a blood vessel growing that's not supposed to be there. It's like a beacon in the fog. Okay, that's a bad situation. That could break open and bleed at any second. This is what his OCT looked like, massively swollen. It's another way of looking at it is through this color map. The white area is massively swollen. So we give him an injection, a couple of injections, and this is what he looks like about after 3 or 4 injections. Have we made progress on this? Yeah, you bet. We've reduced the swelling quite a bit. The white, which was massively thickened, is a lot less. We're making progress, but this is an ongoing thing, okay? We then may add some laser treatment, which are these little spots that we put in here. And this is that same patient now about 6 months later. Okay, we've gotten rid of the swelling. The vision is stable. Sometimes the vision is improved, okay, but it depends. But you can see we're in a much better situation after treatment versus ignoring the problem. Here's another patient. These are what laser scars look like in the back of the eye, just so you know. Okay, that's someone who's had laser in the past. We do an angiogram. The person's got some swelling here. At this point, you guys can diagnose these pictures just as well as I can. Here's some swelling. These little white spots are all the leaking points. They're like the leaking points on a hose. And this person was a candidate just for laser. And laser basically goes in and basically puts patches on these little hoses. It kind of cauterizes the leaks. And this is him about 6 weeks after laser. We can see that we're making progress in reduction of swelling. Last couple slides here, we're going to switch into proliferative diabetic retinopathy, which is what I told you, where blood vessels start to grow abnormally. This is more advanced, and this is what causes blindness. And what happens is, you can see on the nerve here, see these are the normal blood vessels here, these kind of big red ones. But you see those wispy stuff here? Okay, those are abnormal blood vessels that shouldn't be there. They're growing to try to heal. Here's another example. Here's a normal blood vessel. But you see this big thing there, that big red thing there? That's an abnormal one. And these things can be there and break open and bleed just like that, and suddenly you got a cloud of redness and you can't see. And this is what someone might notice. Break it open and bleed, you got all this blood that's now floating in the eye, you can't see through the eye. Ultimately, this blood vessels cause lots of scarring, which is this white stuff. When you get a cut in your hand, scar turns white, scar tissue is white. And when you get scar tissue in your retina, what does scar tissue know how to do? When you get a cut, scar tissue grows in and it does what? Contracts to close the wound, right? Scar tissue was born to know how to contract. That's what it does. So if I get scarring on the film of a camera and it's contracting, what's it going to do to the film? It's going to start wrinkling it. It's going to start pulling it off the back wall of the eye. You're going to get retinal detachment. All kinds of bad things can happen. And this is what someone might see as they're trying to look through the blood. This is a view. It's not a very clear view. They got all this blotchy stuff, okay? We treat that commonly with laser treatment. We still use this as the mainstay treatment for this problem. It continues to be laser. This is laser that's been put in. It's white like that, and then as it matures, it turns black. And ultimately, here was an active situation, just like an active weed, and after lots and lots of adequate laser, this is what we want to see this ultimately looking like, where these red blood vessels become this inactive white situation, sort of like this weed has become inactive. So this is, if someone has advanced retinopathy, what we do is microsurgery, where we go into that same little carpet area, rug area, okay, with instrumentation. We peel up the scar tissue. We do this all in the operating room. You don't want to get to this stage, guys. Here's what the surgery is like. You ready? Here's what the surgery is like. It's like taking wet toilet paper that has gum that's wrapped all inside of it, chewed gum, and trying to peel the tissue paper off the gum without tearing the tissue paper. All right? You don't want to get there. Okay? This surgery, to get from here to here, this is what the person looked like after surgery. That surgery probably took about 5 hours. It's tedious. I don't want to do it either. Okay? You don't want to have it done. Okay? So we don't want to get to this stage, and tragically, unfortunately, we sometimes do. So the last slide is to summarize. Diabetes is a growing problem. Diabetes can cause blindness. It affects your whole body health. Early detection, like anything, is key. There are many different treatments that are effective. You need to get in for a dilated eye examination on a regular basis to be screened for where you are, and you need constant vigilance. I'd like to thank the American Diabetes Association of New York for sponsoring this in conjunction with us.